South Korea quarantined 16,000 people. Within 2 weeks, they had screened over 46,000 people. Every single time you test someone in a hospital setting, you have to just change everything out. Prevention, public health is at a population level, but you really need every single person to do their job. The biggest reason why they've been so successful is because, unfortunately, they had to live through a trial run. I mean, we would say it's a trial run. To them, it was a severe issue for Hong Kong, Taiwan. It was SARS, and for South Korea, it was MERS, where they lived through a pandemic. It wasn't a pandemic of the scale today. However, when they were going through it in 2003 for SARS and 2015 for the MERS, Middle Eastern Respiratory Syndrome, it felt like that because, it lasted between 3 to 6 months. And, South Korea quarantined 16,000 people. They had a 26 mortality rate, case fatality rate for MERS, about 18% for Taiwan for SARS. So it was no small blip in the radar in terms of public health and the severity of those particular infectious diseases. So just living through it, they knew the impact it could take on their public health systems, their medical systems, and the health of their society. So as soon as they got wind of COVID coming from Wuhan, they took action immediately, and the messaging was consistent top down from government officials all the way to local officials. What was so astounding when I looked at the history of these actions, Taiwan actually restricted travel from anyone from Wuhan to Taiwan prior to even the WHO recommending these travel restrictions. So, they were ahead of the curve, even just regarding travel restrictions. When it came down to screening, both Taiwan and South Korea took screening very seriously and rigorously when it came to residents and travelers coming in and flying into other airports. So they had thermal sensors at all the airports to check temperatures. And in terms of testing, South Korea, for example, within a week, what they had learned from their mistakes in MERS was that they lacked the speed of creating tests and implementing tests. So they passed policies and laws such that in a future case of coronavirus or a pandemic situation, private labs wouldn't have to wait for the approval or laws from the government. The government would give them tacit approval saying, hey, go ahead, start to develop these non-approved screening kits. We're gonna use them, and then we promise that we're gonna make them within regulations. So that cut down a lot of lag time in terms of just the number of tests, and the big consequence of that is they were able to screen with much more rigor and cast a wider net from the get-go compared to Italy, Germany, United States, and Hawaii, who were dealing with just getting screening test kits. So within 2 weeks, they had screened over 46,000 people versus the United States was like 400 something people. And both South Korea and the United States had their first confirmed test on the same day, 20 January. And yet, as of 3 to 4 days ago, South Korea tested about 5.2 people per 1,000 versus the United States 2.5 per 1,000. So about double the amount. And yet, they both had their first confirmed case on the same day. That's a great question, because that once again links the testing to the PPE, because those are very closely tied, and that's a secondary order of effect that a lot of people don't think about when they just advocate for wide testing. And we see that in the state of Hawaii as well. What South Korea really did a great job on within 2 weeks, they had a lot of testing kits, but they also set up 600 remote testing sites away from the medical facilities where the most vulnerable were taken to for care. So you had, they were the first to develop these drive-through testing sites, but also just remote testing areas where it'll be you're set up. The tester is set up in a phone booth. They have their hands in these latex gloves, so they're not burning through PPE for every single test, which is unfortunately what we saw in the United States and Italy, where every single time you test someone in a hospital setting, you have to just change everything out, which is the best practice. However, once again, like everybody is now seeing, it's a waste of PPE. It should be saved for the medical providers to care for those who are sick due to COVID. So what South Korea did is they limited the impact on the physical equipment by setting up infrastructures that reduce the amount of wear and tear on the PPE for testing. So what we've seen in Korea and a lot of times in China is that when you get tested and you test positive, you're actually isolated from your family. So you're either put in a hotel or a government facility where you're then isolated for a certain amount of time so that you're not infecting your loved ones. And for example, in Hawaii and even Asia, there's a lot of multi-generational living, right? And that's important because we know that age is a huge risk factor for potential risk of death from COVID. So they definitely thought through that process of if you did test positive, what you would do. The other thing that South Korea and also Taiwan has done is if you test positive, and this speaks to the impact of the rest of the population, is the government will then get the information and send it to people who you may have been exposed to so that they can start to conduct contact tracing, which is important because it's not just the person who tests positive, but it's seeing who else they might have exposed, because then you have these secondary and tertiary exposure effects that, you might remove one person, but if you were positive and you were exposed to 50 other people, then those 50 people could be exposed to 50, so it's exponential. So it's important to really get that information out. So what South Korea did is they developed an app called Corona 100, which is basically, as people who test positive are made known to the government, they send that out to the app that everybody has on their cell phone, and then they warn people who were around that same vicinity, hey, this person tested positive, just give me a heads up, were you exposed? And also, if someone was potentially exposed to, then they would track their movements with credit card data, cell phone data, GPS data, and then blast that out to people within that certain radius and let them know, hey, you have someone who's potentially positive, be aware of that and potentially stay away from these areas. So once again, using data to assist with not only contact tracing, but also daily living as well. One has to just look at the cultural differences between Italy, Germany, and the United States versus Taiwan, Hong Kong, China, Japan, Korea, where it's more of a collectivist society. In these Asian countries where they oftentimes are trained at a very young age to put the greater good of the society and their family over themselves individually. And therefore, when it comes to public health practices, they're more likely to comply because it's been ingrained in them culturally that, yes, that's something we should do. It's okay if I wear a mask, even though it might be uncomfortable, because it's better for the public. While we do see some pockets where there is public compliance, it's less widespread in the United States, in Europe, and so yes, public compliance is much bigger. The United States has amongst the brightest and most advanced researchers and technology and databases available. What makes it difficult is the type of health insurance system and healthcare that the United States implements versus Korea, Taiwan, Hong Kong, where it's very one system based, which is another debate for itself. However, the advantage that it does have is all that data is in a single repository. Right. So for example, Korea, it's a government healthcare system, so the government has access to data for 99% of the population, and so that's important for twofold. One, people aren't afraid to seek healthcare because it's covered by the government. So once again, you have that clinical aspect that's taken care of. Two, all that data can be pulled and shared with researchers, with government officials, with much greater ease, because it's all in one system, versus even in Hawaii, you have Kaiser, you have HMSA. It's very hard as a researcher to get data that's all together in a very time. It's possible, but it's a lot less efficient in terms of dealing with something that's evolving day to day and that requires expediency. We love data. If you could give us all the data in the world, you would make us happy. However, we understand, in the United States and all around the world, there are patient privacy acts for, we have HIPAA, and therefore if I were to do a research project, it would always go through IRB at UH and whatever institution I'm working with. So we understand and we obviously respect and understand why these laws are in place. However, when we're dealing with a very serious, fast-acting, highly contagious pathogen like COVID, SARS, or MERS, we've seen the successes in Korea and Taiwan where they have amended policies for specific situations like a pandemic to make it easier to release data that not only serve the good for researchers, but also private citizens so that we can protect ourselves and take measures individually to avoid areas where we could potentially be exposed to. We need to first understand to what extent is COVID affecting populations worldwide, nationally, statewide, within certain zip codes, because only then can we start to make recommendations and then backtrack and figure out, okay, what really caused the surge in cases from an epidemiological point of view? Was it age? Was it gender? Was it exposure? Was it travel? But we need to first and foremost know the current situation on the ground, which is why, as epidemiologists, we advocate testing because it gives us the information, and then we can inform the policymakers who are going to make these broad, changes to policy or these policies that will impact the whole community, the whole population, such as the social distancing mandate that the mayor and the governor enacted. The second step is then to take data from hospitals, from states, and really start to analyze it on a more granular level, and then work with virologists, work with immunologists to then look at specific comorbidities. So that's our next step. And some of the epidemiologists at China and Korea, where they're kind of moved from the crisis phase to the research phase, that's what they're starting to look at. But in the United States and Italy and Germany, even researchers and academics, we're still in the crisis mode, supporting our local and national public health infrastructures to just figure out what's going on the ground.